Okay, let's unpack this.
Do it.
We're diving into a really crucial topic today, hemostasis. That's the body system for stopping bleeding.
Right.
And maybe more importantly, the disorders, these really paradoxical conditions that pop up when that system goes wrong.
Yeah, it's fascinatingly complex.
You're basically using Porth Pathophysiology as our guide for this deep dive, foundational stuff.
Solid source.
Our mission here is to walk you through that normal process, step by step, how blood clotting works.
The baseline.
Exactly. And then show how things can go off the rails, leading to these two extremes, either too much clotting thrombosis, hypercoagulability,
Dangerous clots.
or the opposite, failure to clot, which means, major bleeding.
Yeah.
Hemorrhage.
It really is a biochemical tightrope, isn't it? So finely tuned, you've got all these activators, inhibitors. It's a constant balancing act. The goal is keeping blood fluid inside of vessels, but ready to solidify instantly if there's a break.
So understanding the normal steps is key.
Absolutely. If you nail the normal process, who the players are, what they do, then all the disorders, all the clinical stuff we'll talk about, it just makes so much more sense.
Okay, let's start there then. The ideal scenario. You get cut, the body reacts. 3 stages to seal that vessel wall.
Right.
Stage 1 kicks in super fast. Vascular constriction.
Yeah, that initial spasm. It's brief, but it's the first move to cut down blood flow.
What triggers it?
Well, there's the injury itself, local nerve reflexes play a part, but also chemical signals, big ones.
Like?
Platelets release something called thromboxane A2, TXA2, and the damaged lining of the vessel, the endothelium, releases endothelin-1.
Endothelin-1, I remember that one.
Yeah, it's actually the most potent vasoconstrictor we know of. Yeah. It really clamps things down.
But even right there, you see the balance, right? Because the nearby healthy endothelium is doing the opposite.
Exactly. It's releasing prostacyclin. That causes vasodilation. And crucially, it stops platelets from sticking where they shouldn't.
Like a local negotiator. Keep the clot contained.
Precisely. So once the flow slows down a bit, we hit stage 2, formation of the platelet plug.
Okay.
For smaller nicks and cuts, this plug might actually be enough to seal the deal entirely.
And platelets are thrombocytes.
Thrombocytes, yep. They circulate normally, around 150,000 to 400,000 per microliter. Their production line is managed by a protein called thrombopoietin.
So how does the plug actually form? You said 3 parts.
Yeah, kind of like a little 3-act play. First is activation and adhesion.
Activation meaning?
The platelets literally change shape. They go from these smooth little discs to spiky activated spheres, and then they need to stick.
Stick to what?
To the collagen fibers that get exposed when the vessel wall is damaged.
And they need help sticking.
They absolutely do. They need a cofactor called von Willebrand factor, or VWF.
VWF.
Got it. Think of VWF as like molecular Velcro or glue. It links a receptor on the platelet surface directly to that exposed collagen. No VWF, no adhesion.
Okay, so they're stuck. What's next?
Aggregation. The platelets that just stuck. They get activated and dump out the contents of their little storage granules.
What's in the granules?
Things like ADP and, importantly, more TXA2.
Ah, so it feeds back on itself.
Exactly. It's an amplification loop. ADP and TXA2 basically shout for backup, pulling in more platelets, making the clump grow really fast.
That's the final step for the plug.
Stabilization. You need to make that clump solid. This involves specific receptors on the platelet surface, the glycoprotein IBA receptors.
GPIDA.
Okay.
These receptors grab onto fibrinogen, which is normally just floating around dissolved in the blood.
And that does what?
The fibrinogen acts like a bridge linking platelets together. That's what really cements the aggregate into the primary plug.
So we have a plug, but it's maybe still a bit soft.
Right, it needs reinforcement.
Which brings us to stage 3, blood coagulation, the famous cascade.
This is where fibrinogen gets converted.
Precisely. This whole complex process turns that soluble fibrinogen into tough, insoluble fibrin strands. Think of it like weaving a net over the platelet plug, making it super strong.
Okay, the cascade. Lots of factors involved here. Roman numerals.
Yep, most are proteins, and here's a key point. They're mostly synthesized in the liver.
Liver function is critical then.
Hugely critical. And for some key factors like 2, 7, IX, and X, plus prothrombin and protein C, that synthesis absolutely requires vitamin K.
Vitamin K.
And don't forget calcium, factor IV. It's needed for almost every single step in this cascade. It's indispensable.
So the cascade itself Pathways, two of them, like in figure 22.2 from the book.
Exactly. You've got the intrinsic pathway. Think intrinsic because everything needed is already within the blood itself.
How does it start?
It kicks off when factor XII encounters collagen exposed in the injured vessel wall. It's a bit slower, takes maybe 1 to 6 minutes.
And the other one?
The extrinsic pathway. Think extrinsic because the trigger comes from outside the blood vessel.
How does that work?
It starts when tissue factor, sometimes called thromboplastin, gets released from the damaged tissues around the vessel. And this one is fast, like 15 seconds fast.
Wow, big difference.
Huge. It's why major trauma or sepsis, where tons of tissue factor gets dumped into the system, can trigger clotting so rapidly and dangerously. It kind of shortcuts the process.
But both pathways lead to the same place eventually.
They do. They both converge on activating factor X. That's the start of the common pathway.
Yeah, factor X does what?
Activated factor X converts prothrombin into thrombin. And thrombin is the real star enzyme here.
Why is that?
Thrombin does the main job. It snips fibrinogen to create those fibrin monomers that then link up to form the stable fibrin mesh. That's your final solid clot.
Okay, solid clot formed, but the body needs breaks, right? You can't just keep clotting forever.
Absolutely not. You'd clot solid. So we have built-in anticoagulation mechanisms. Key players are antithrombin III.
Antithrombin. Sounds like it stops thrombin.
It does. It neutralizes thrombin and also factor VIII. And fun fact, this is where heparin works clinically, it massively boosts antithrombin III's activity.
Ah, okay. Any others?
Yep, protein C and protein S. They work as a team to inactivate factors V and VIII, putting another brake on the cascade.
So the clot is formed, controlled. What happens next? Does it just stay there?
Not usually. Within about 20 to 60 minutes, you get clot retraction.
Retraction.
The platelets in the clot actually contain contractile proteins, like tiny muscles. They contract, squeezing out the serum and pulling the edges of the broken vessel closer together. Aids healing.
What if that doesn't happen well?
Often points to a low platelet count or poor platelet function.
And finally, it needs to dissolve.
Right, once healing is underway. That's clot dissolution or fibrinolysis.
How does that work?
There's an inactive enzyme precursor called plasminogen circulating. Another activator, tissue plasminogen activator, or TPA.
TPA, the clot buster drug.
That's the one. The body makes its own. TTA converts plasminogen into active plasmin. And plasmin is like Pac-Man for fibrin. It just digests the fibrin strands, dissolving the clot, the cleanup crew.
Okay, so that's the normal, elegant system, finely tuned, as you said.
When it works right, yeah.
Now let's look at the flip side. When that tightrope gets pulled too far towards clotting, hypercoagulability, basically being prone to thrombosis.
Right, forming clots when and where you shouldn't. And clinically, it helps to think about where the clot forms. Arterial versus venous.
What's the difference?
Arterial thrombi, the ones causing heart attacks. Strokes usually happen where blood flow is fast and turbulent, often over-damaged endothelium, like an atherosclerotic plaque.
So they're made of?
Mostly platelets, dense clumps of activated platelets.
And venous thrombi, like DDTs.
Deep vein thrombosis, yeah, or pulmonary embolism if it breaks off. These tend to form where blood flow is sluggish, stagnant. Think pooling in the leg veins during bed rest.
And because it's slow.
The coagulation cascade has more time to get going. Yep. So venous clots tend to have a lot more fibrin mixed in with the platelets. It's a different structure.
Okay. So what increases the risk? Let's start with platelets. Increased platelet function.
Big factor, especially for arterial clots. Anything that disturbs flow or damages that endothelial lining makes it easier for platelets to stick and activate.
Like what?
Atherosclerosis is a major one. Smoking, diabetes, high cholesterol, they all contribute to endothelial damage.
But what if you just have too many platelets?
That's thrombocytosis, generally defined as a count over 1 million per microliter.
1 million, wow. Normal was up to 400,000.
Right. And there are two main types, primary or essential thrombocytosis.
Primary.
It's a problem with the source. A myeloproliferative disorder, basically, the bone marrow stem cells are overproducing platelets uncontrollably.
What does that cause? Just clots.
Here's where it gets weird. Patients often have both thrombosis, DVTs, PEs, and bleeding problems.
Both?
Because while the number is high, the quality of those platelets is often bad. They might clump inappropriately, but not function correctly when needed for normal clotting. They can also get this painful throbbing in the fingers and toes called erythromelalgia.
Okay, that's primary. What's secondary?
Secondary or reactive, thrombocytosis is much simpler. The body is just reacting to something else, maybe tissue damage from surgery, a bad infection, chronic inflammation.
And the platelets are okay?
Yeah, and secondary, the platelets themselves are usually normal, just numerous. The risk is generally lower than in primary.
All right, so that's platelets. What about the cascade itself? Can that get hyperactive?
Absolutely. This raises the question, what speeds up clotting? Acquired factors are common.
Like?
Venous stasis is huge. Prolonged bed rest, major surgery, heart failure, blood just sits there.
And that allows?
Activated clotting factors to hang around longer and bump into each other instead of getting washed away and neutralized by those inhibitors like antithrombin III.
Makes sense. Anything else acquired?
Yep.
Hyperestrogenic states. Think pregnancy, postpartum, or even taking oral contraceptives. Estrogen seems to increase the levels of certain clotting factors.
Oh, interesting.
And malignancy. Cancer is a major risk factor. Tumor cells can release tissue factor, kicking off that extrinsic pathway aggressively.
Okay, those are things you acquire. What about inheriting a tendency to clot?
Very important area. The most common inherited cause by far is Factor VIII.
Factor VIII, what is that?
It's a specific mutation in the Factor V gene. Remember protein C, one of our natural anticoagulants? Its job is to shut down Factor V.
Right, one of the breaks.
Well, in Factor VIII, the Factor V molecule is mutated so that protein C can't bind to it properly. It's resistant to being inactivated.
So the break fails.
Essentially, yeah. Factor V stays active longer, leading to more thrombin generation, increasing the risk for clots, especially DVTs. It's also linked to problems in pregnancy, like VTE or preeclampsia.
Common, you said.
Relatively, yeah, especially in populations with European ancestry.
Any other inherited ones worth noting? There are others, like prothrombin gene mutations or deficiencies in protein CS or antithrombin III, but Factor VIII is the big one.
Okay, one more acquired condition listed here, antiphospholipid syndrome.
Ah, yes, APLS. This is an autoimmune condition. The body makes antibodies, usually Ig type, that mistakenly attack certain proteins bound to phospholipids on cell membranes.
And that causes clots.
It does, paradoxically. It leads to widespread venous and arterial thrombosis. It's also notorious for causing recurrent miscarriages. And confusingly, patients often also have low platelet counts, thrombocytopenia.
Autoimmune, clots, low platelets, pregnancy loss. Complex picture.
Very. Needs specialist management.
Okay, we've covered too much clotting. Let's swing the pendulum the other way. Not enough clotting. Bleeding disorders.
Right. The flip side of the coin, when the system fails to seal breaks adequately.
Where does bleeding usually show up first?
Typically, spontaneous bleeding involves the small vessels, capillaries, and venules, especially in the skin and mucous membranes.
And clinically, what does that look like?
You see characteristic skin signs, tiny pinpoint red or purple dots, those are petechia, and larger pupil areas, basically bruises. That's purpura.
Petechia and purpura. Any distinction?
Yes, and this is a really useful clinical clue. Petechia are almost exclusively seen when the problem is a low platelet count thrombocytopenia.
Ah, okay, good tip. So thrombocytopenia.
Defined as?
Platelet count less than 150,000 per microliter. Remember, normal is 150K to 400K.
What causes low platelets?
You can group the causes into sort of three main buckets. One, decreased production in the bone marrow.
Like it.
Aplastic anemia, leukemia, certain infections like HIV or cytotoxic drugs used in cancer chemo. The factory is shut down.
Bucket 2.
Increased sequestration. Platelets get trapped somewhere. The usual culprit is an enlarged spleen, splenomegaly. The spleen holds on to too many platelets.
And bucket 3.
Reduced survival or increased destruction in the circulation. They're being made okay, but they're getting chewed up too fast.
Okay, let's talk specifics under that destruction category. Drug-induced immune thrombocytopenia, DITP. Yeah, this one's fairly straightforward. Certain drugs, some antibiotics, even aspirin, heparin, we'll talk about separately, can trigger an immune response.
Oh.
The drug acts like a hapten, binding to platelets, and the immune system forms antibodies against that drug-platelet complex. Those antibodies then lead to platelet destruction, lysis.
Does it happen fast?
Very fast drop in platelet count after exposure to the drug. But the good news is it usually resolves quickly once you stop the offending drug.
Okay, now, heparin-induced thrombocytopenia, HIT. You flagged this one.
Yes. HIT is critically important and deeply paradoxical. It's also an immune reaction, but it's specifically against a complex formed between heparin and a protein released by platelets called platelet factor IV, PF4.
So antibodies form against heparin PF4 complex.
Exactly. And these antibodies bind to platelets. Now, here's the twist. While this does lead to platelet removal and thrombocytopenia,
The dangerous part is
the binding of these HIT antibodies activates the remaining platelets massively, and it can also damage endothelial cells.
activate platelets.
Yeah.
But heparin is an anticoagulant.
That's the deadly paradox. This immune reaction turns the anticoagulant heparin into a trigger for widespread life-threatening thrombosis, arterial and venous clots.
So if a patient on heparin suddenly drops their platelet count,
You have to suspect HIT. It's a medical emergency. Stop all heparin immediately, including flushes, and you have to start a different non-heparin anticoagulant right away, even though the platelet count is low because the thrombosis risk is so high.
wow, okay, that's a crucial one. What about ITP, immune thrombocytopenic purpura?
ITP is another autoimmune one, but it's different from HIT. Here, the body makes autoantibodies directly against platelet glycoproteins, often those GPI-BII receptors we talked about.
So the immune system attacks the platelets directly.
Yes, and these antibody-coated platelets get gobbled up primarily by macrophages in the spleen. Spleen is the main site of destruction.
How does ITP present?
Often with bruising, petechia, sometimes gum bleeding, nosebleeds. In women, heavy menstrual bleeding can be a major issue.
Okay. And one more specific, thrombocytopenia, TTP, thrombocytopenic purpura?
TTP is rare, but often devastating if not recognized quickly. It's part of a group called thrombotic microangiopathies.
What's the underlying cause?
It's usually caused by a severe deficiency of an enzyme called 8-MTS13.
8-MTS13. What does that do normally?
Remember von Willebrand factor, VWF? It circulates as these large multimeric chains. 8-MTS13 acts like molecular scissors, chopping these large VWF multimerors into smaller, less sticky pieces.
So in TTP, the scissors are missing.
Exactly. Without 8-MTS13, you get these ultra-large, super sticky VWF multimerors accumulating in the blood.
And they cause?
They cause platelets to aggregate spontaneously onto them, forming small clots, microthrombi, throughout the small blood vessels.
Occluding the vessel.
Yes. This leads to a classic, though not always complete, pentad of findings. Thrombocytopenia, platelets get consumed in the clots, microangiopathic hemolytic anemia, red cells get shredded passing through clogged vessels, kidney failure, fever, and fluctuating neurologic signs. It's another emergency.
Okay, so those are all platelet number problems. What about issues with the clotting factors themselves?
Right, coagulation factor deficiencies. These tend to cause a different pattern of bleeding.
How so?
Less petechia, more large bruises, ecchymoses, deep tissue bleeding into muscles, hematomas, and characteristic bleeding into joints, especially after minor trauma or prolonged bleeding after surgery or dental work. GI bleeding can also occur.
Can these be acquired?
Definitely. Two main acquired causes. First, liver disease. We said the liver makes most factors, so severe liver disease means reduced factor synthesis.
Makes sense.
Second, vitamin K deficiency. Remember, factors 2, 7, IXX, protein C need vitamin K for activation. Without it, the liver makes the proteins, but they're inactive, non-functional.
Why would someone be vitamin K deficient?
Newborns are born with low stores, which is why they get a vitamin K shot. Also, broad-spectrum antibiotics can wipe out gut bacteria that normally produce some vitamin K malabsorption syndromes too.
Okay. And inherited factor deficiencies.
The most common inherited bleeding disorder overall is actually von Willebrand disease, VWD.
Affecting VWF.
Yes. Either a deficiency or a defect in the VWF protein. Since VWF is needed for platelet adhesion and it stabilizes factor VIII in the circulation, defects cause problems with both platelet plug formation and the coagulation cascade.
Is it severe?
Usually it's quite mild, affects maybe 1–2% of the population, often presents as nosebleeds, heavy periods, easy bruising.
And the most famous one.
Hemophilia. Specifically, hemophilia A, which is factor VIII deficiency.
Factor VIII. Okay.
It's an X-linked recessive disorder, so it primarily affects males. Severity depends on how much functional factor VIII they have. Less factor means more severe bleeding.
What's the hallmark of severe hemophilia A?
Spontaneous bleeding, especially into large joints, knees, elbows, ankles, hips. It's called hemostasis.
And that causes long-term problems.
Yes, repeated bleeding into a joint causes inflammation, cartilage damage, and eventually chronic pain and joint destruction, a condition called hemophilic arthropathy. Treatment involves replacing the missing factor VIII.
Okay. One last category here.
Yeah.
Vascular disorders, bleeding, but
the platelet count is normal, and the coagulation tests like PT and APTT are also normal. The problem isn't the blood, it's the blood vessels themselves.
how so?
Either the vessel walls are structurally weak or they're damaged by inflammation or immune processes. This leads to easy bruising, purpura, but usually not the deep bleeding seen with factor deficiencies.
Examples.
Classic one is scurvy vitamin C deficiency. Vitamin C is essential for collagen synthesis, and weak collagen means fragile vessel walls. Also, Cushing disease excess cortisol leads to protein wasting, weakening vessel support, and you see it in older adults, senile purpura, just due to age-related loss of subcutaneous fat and collagen support around small vessels.
All right, we've covered too much clotting, too little clotting.
Yeah.
Now for the one that does both. The ultimate paradox, DIC.
Disseminated intravascular coagulation. Yeah, this is probably the most complex and frightening of the hemostatic disorders, because, as you said, it involves widespread clotting and severe bleeding, often happening at the same time.
How on earth does that happen?
It starts with some massive insult to the body that triggers systemic, runaway activation of the coagulation cascade.
What kind of insult?
Common triggers include severe sepsis, major trauma, especially crush injuries or burns, certain cancers, and obstetric complications like amniotic fluid embolism or placental abruption.
And these triggers release.
Huge amounts of procoagulant substances, like tissue factor, directly into the circulation. This overwhelms all the natural anticoagulant controls. You get explosive, widespread thrombin generation.
So clots start forming everywhere.
Exactly. Tiny fibrin clots, microthrombi, deposit throughout the microvasculature, small vessels in organs like the kidneys, lungs, brains, skin.
What does that cause?
Widespread vessel occlusion leads to tissue ischemia, hypoxia, and ultimately organ damage and failure. You see signs of kidney failure, respiratory distress, neurologic changes.
Okay, that's the clotting part. Where does the bleeding come from?
This is the crucial second phase. That massive, uncontrolled clotting consumes coagulation factors, fibrinogen, factors VIII, and platelets at an incredible rate.
Uses them all up.
Pretty much. The body essentially exhausts its supply of clotting components, trying to form all these tiny, widespread clots.
Leaving nothing left for actual injuries.
Exactly. So, paradoxically, while microclots are blocking vessels, the patient develops a severe bleeding tendency because there are no factors or platelets left to form a normal clot at sites of injury, or even just puncture sites like IV lines.
So you see both things clinically.
Yes. The clinical picture is often dominated initially by the bleeding petechiae, purpura, oozing from venipuncture sites, potentially massive hemorrhage. But underneath, the organ damage from the microthrombi is progressing, leading to multi-system organ failure. It's a devastating cycle. #outro.
Wow. Okay, so putting it all together, we've really walked that tightrope, haven't we?
We have. From the normal, careful steps of vessel constriction, platelet plug, and fibrin mesh.
The dangers when it tips too far one way, hypercoagulability. Things like Factor VIII causing that brake failure, or TTP with those sticky VWF chains.
And then tipping the other way into bleeding disorders, like the factor deficiencies in hemophilia or the platelet destruction in ITP.
And finally, the chaotic failure of DIC, where you get both clotting and bleeding systemically.
It really highlights how critical that balance, that equilibrium is. Too much clot blocks flow, too little leads to hemorrhage. And DIC is just catastrophic loss of control.
So, thinking about all this, especially the platelet side, here's something to chew on. We talked about platelet mediators like TXA2 and ADP being key for activation and aggregation.
Right, early steps in plug formation.
Given how common cardiovascular disease is, and how widely drugs like daily low-dose aspirin, which hits TXA2, or clopidogrel, which blocks ADP receptors, are used.
Yeah, millions take them.
What's the real long-term impact of that chronic daily pharmacological nudging of the system? How profoundly are we altering the intrinsic hemostatic balance in these high-risk populations, and what does that mean for managing them down the line?
That's a really important question, a definite point for reflection.
Well, thank you for joining us for this deep dive into the really complex world of altered hemostasis.
My pleasure. It's vital stuff to understand.
We hope this has been a useful shortcut for all you learners out there to get informed.